It requires a huge amount of resources. It is a high-stress situation requiring multiple teams to coordinate, and so you need to be an experienced program to do it. Second, identify your candidates early so that you're well prepared and you're not struggling in the last minute.
Welcome back to PedsCrit. I'm Zach Hodges, a pediatric ICU fellow from UT Southwestern in Dallas.
And I'm Alice Shanklin, a critical care fellow in Washington, D.C.
We're very excited to have Dr. Lakshmi Raman with us today. Dr. Raman is a professor of pediatrics here at UT Southwestern and a practicing pediatric intensivist with me here at Children's Medical Center, Dallas. Here, she serves as the medical director of Extracorporeal Membrane Oxygenation, or ECMO program, and she is also active in ELSO and serves as the chair of publications. She, in fact, co-authored the 2021 ELSO Pediatric ECPR guideline that we're discussing today.
Zach, you found another guideline author, and I am so excited. This episode is fantastic because making the decision and actively cannulating a patient that you're coding is really one of the most stressful scenarios, I would argue, in the human experience, but definitely in the PICU or the cardiac ICU. And so having these concrete clinical tips from someone who's been through it and someone who's an expert is incredibly valuable.
Yeah, we hope this conversation can provide some clarity for this really difficult decision that happens in a really high stress situation. So let's get right to the content. Welcome back to PedsCrit. I'm Zach Hodges. We're here with Dr. Lakshmi Raman. We're so excited to have her on the podcast today to talk about this topic, ECPR. Lakshmi, welcome to the show.
Thanks, Zach, for having me on the podcast. Hope it will be educational.
Oh, I think so. To get things started, would you tell our listeners a little bit about yourself, and feel free to include something that you enjoy outside of medicine?
I'm Lakshmi Raman. I've been a pediatric intensivist for the past 15 years in the United States. I did my medical school in India and then traveled across the globe. I was in England for about 2.5 years. I practiced in the Middle East. I was a general pediatrician for about 5 years before I came to the United States and decided that I hated being a general pediatrician from the bottom of my socks. So here I am, an intensivist. Outside of pediatrics, what do? I do actually only very little love cooking. I cook mostly Indian food, but I also cook other cuisines. And my son is a big food critic, and so that has made me a better cook. I do enjoy traveling with my husband, who's a big traveler. So I've traveled across the world for other than some parts of Africa.
Very fun. I know cooking is a great stress relief for me as well.
Yes, it's a great therapy for me. That's why I love to cook, because as the dishes come along, I feel so nice. I feel like I'm in control, which you're not very many times in the ICU.
Oh my goodness, that's funny.
Yes, yeah.
After speaking with you briefly before, I knew that ECMO, you didn't necessarily have access to that at your previous maybe work institutions. How did you become interested in ECMO and then later ECMO-related research?
So my residency was in New York. I didn't have any exposure at all to ECMO. And then when I joined my critical care fellowship, in those days, we didn't have all the orientation and the lectures that you all get these days. So the first day I was on call, there was a patient who was brought back on ECMO, and that's my first vision to the ECMO machine. And it was mostly cardiac ECMO that I did during my fellowship. And then because of my visa status, I had to do a waiver job, which was a small ICU with not even extracorporeal support. And then I joined UT Southwestern and Children's Health in 2008. And this was my first exposure to a lot of respiratory ECMO, including neonatal ECMO, as we do neonatal ECMO in the pediatric intensive care unit here. And I found it to be really intriguing and exciting because this was something that I was not comfortable, and it gave me an opportunity to learn. So that's how I became interested in ECMO. And really, we started having a dedicated ECMO team in 2009 into 2010. I can't take credit for that. The previous medical director here, she was here for a long time, Dr. Meridia Thompson, who's still considered my guru for ECMO. She started the ECMO team, and I was not a member of the team until late 2012 when Jim Thomas was then the ECMO medical director, and he, I want to say, twisted my arms to get on the ECMO team.
But encouraged.
And then in 2013, I think he had decided to move on to greater prospects, I guess. And then I was suddenly now the medical director of ECMO, and now I really had to learn what ECMO was and all the intricacies of that. And in terms of research, really, I was always interested in brain injury, and neurocritical care was my area of interest. So I initially did bench research as a part of my fellowship because I felt this was my only chance to be in a lab. I had never done any research before during my medical school or in my initial days. And so I thought this may be my best opportunity to learn those skills. And so I joined bench science and I was really excited. I did some work with chronic hypoxia initially in a rat model and then in a mouse model when I moved to UT Southwestern. But then realized as I was going through the journey of research that it was very difficult to keep up with the growing field as a clinician. And then when I became the ECMO medical director, I said, how am I going to transition this brain injury into ECMO? And we all know that in ECMO, they have significant neurological complication, which is often a devastating complication. And so I've really dedicated the last 10 years of my ECMO career into understanding neurological injuries and neuromonitoring and predicting neurological injuries.
So interesting, and definitely further opportunities for to discuss further on the podcast. So lots of opportunities inside of research, especially for fellows in ECMO.
Yeah.
Any general recommendations or advice you might have for fellows early in their training about how would they best get involved in this area?
Yeah. I think your questions have to be simple because one, during your fellowship, you have a defined timeline. So I always tell fellows that you want to take on a project where you feel you are in control. So a small, simple question. And also I advise fellows that your research training during fellowship is really a marathon training and not a sprint run. So learning the steps of research, IRB approval, simple steps. And I always encourage fellows to think of submitting a grant, whether you need the money to do it or not, because it helps you really crystallize your thought process. And then trying to put together a simple study. And I think there are immense opportunities in critical care in general. And so even though I'm an ECMO medical director and do a lot of my research in ECMO, I'm still interested in traumatic brain injury. I do some work there, and I'm helping one of our fellows working on a prediction model in the cardiac ICU. So I do have other interests as well. So I would say pick a project that you feel you're in control, a small one, and go through the journey so you learn the essential skills that can then help you go through your journey of what you want to do after your fellowship. I don't know if I answered that question.
I think so. I think having a well-defined, achievable goal, but also having a mentor like yourself would be helpful as well.
Yes, I guess. Yes.
So as we kind of move on to jump into our topic today, ECPR, how about I give us a case? So you're back in the cardiac ICU. You have a 4-month-old female who's less than 1 day post-op AV canal repair. Her course has been complicated by low cardiac output syndrome, and she subsequently develops cardiac arrest. So you start high-quality CPR through Powell's algorithm. You give your first dose of epinephrine, and then the charge nurse asks you, should we activate the ECPR team? So before we go into all details of the case, what exactly is ECPR? How is it different than just ECMO?
So we say it is institution of ECMO as you're doing active CPR or within 20 minutes of return of spontaneous circulation. So what the goal is that when you start CPR, many times you're not sure what the duration is going to be. And also, depending on the candidate, do you think the reason for the cardiac arrest, is that something that you can bridge if you're able to return spontaneous circulation? In fact, if you go back to the story of why even ECMO came to the old days of Gibson and his wife Mary, you know how Gibson thought about ECMO? One night he had a patient with a massive pulmonary embolism dying right before him. And he thought, if only I could take that blue blood from that patient and be able to circulate and bypass that clot and give that red blood back to the patient, can I keep this patient alive? And that was the birth of ECMO. So I think that's what really we are thinking about when it comes to ECPR. can I bridge this patient until whatever is the reason that this patient had a cardiac arrest to give oxygenated blood that I can pump into the patient? That's all you're trying to achieve in ECPR.
Yeah, that's helpful. And hearing the historical content is definitely fun. So why should we offer ECPR? Does it offer a better outcome for our patients?
Yes, and there are multiple systematic reviews that have compared ECPR to conventional CPR, both in adults and in pediatrics, that have shown that ECPR has better outcomes than conventional CPR. So yes, the short answer, should you be offering ECPR? Yes, but who do you offer to? And I think that's a bigger challenge.
Sure. Yeah, and what's something we'll discuss more definitely in our conversation today. So practically speaking, what are the goals of ECPR? What are we exactly trying to accomplish?
I think what you're trying to accomplish is that if you don't have return of spontaneous circulation, you are able to now establish flows in this patient with the use of a mechanical pump. That's exactly what you're trying to do. So by inserting cannulas in the patient, so it's a surgery that has to happen as you're actively doing CPR. So that's why high quality CPR, as this is being done, is very important, because you have to bridge the patient until you are able to establish flows by ECMO. And so that's what really we are trying to achieve. And then you wait to see if the process that initiated the CPR can be reversed. And then you are able to come off ECMO and the patient is back to their pre-CPR status, if not even better.
Right. And it's not always used as a bridge to definitive management. There's other roles for ECPR other than just therapy, right?
Definitely. Yeah. So sometimes we use ECPR as a bridge to decision or a bridge to transplant. Sometimes if you know that the heart is not going to recover, at least this gives you the time to work up the patient to see if they are transplant candidates and can they be listed. And if so, then you can even bridge them to a VAD, a support therapy, and then eventually to transplant. Sometimes you don't know what caused the arrest, and then this gives you an opportunity to make the diagnosis and say, is this something that I can bridge them to either recovery or to transplant? And if not, do I have to withdraw this patient from support? And that is very helpful as well, that you feel like you've not condemned this patient to death without offering this treatment. So it can be therapy to recovery, it can be bridge to transplant, it can be a bridge to decision making.
I think it's really helpful. As we get to the next question, I think this is one of the most important questions of our conversation today. It's definitely what I think about the most in the moment of a child arresting. Which patients are most likely to benefit from ECPR? Who should we consider this therapy for?
I always think that's the $1 million question at the bedside, but I think what has helped is all the studies, the experiences that you have gained along the way. For sure, cardiac medical patients have the highest potential. And in the PICU, their role is very minimal. For instance, if you have an asthmatic patient who suddenly arrests, then you may be able to bridge them. Or let us say in the ER, there is a patient who's got a foreign body who's going to the operating room for removal of the foreign body. You can have ECMO as a standby, and as you are trying to remove the foreign body of the patient arrest, then you cannulate them and support them while you are retrieving the foreign body. So there is a role for these patients outside the cardiac ICU, but thinking about who's a candidate is always very helpful. So that is why, as you know, Zach, in our ICU, both in the cardiac and in the PICU, we always think about who is a candidate for ECPR. And not every patient who is an ECMO candidate is not an ECPR candidate. And I think that is the distinction we really have to make. And so that is always very helpful, so that you're not fumbling at the time when the patient arrests. You've thought ahead, you've prepared ahead, and then always when you are prepared, all of us know your outcomes are better, you do things much better.
Yeah, I think that's helpful. Having that mental model, identifying who's high risk for arrest, going ahead and deciding before it even happens what's going to be our next steps. We'll talk more about the discrepancy between maybe ECPR versus ECMO candidate later in our talk. Before that, why do you think cardiac patients tend to do so much better from ECPR as compared to like regular PICU patients?
I think any cardiac patient, they do have a reversible, many times it is either low cardiac output syndrome, they have rhythm abnormalities, which are reversible, and also they are more likely to be in a low flow state rather than a no flow state, and they have oxygenated blood going through them. I mean, if you think of a respiratory arrest, even if you do effective CPR and cannulate them, if you have not had the ability during that CPR to have some effective oxygenation to the patient, which is very difficult in a respiratory arrest, then, for instance, if it is, say, occluding foreign body, or you don't have an airway, or whatever is the reason for a respiratory arrest, or you have a tension pneumothorax or something like that, unless you've relieved that underlying reason for their respiratory arrest, it's very difficult to have good outcomes. And that is why I think in the cardiac population, you have better outcomes, because you do have some oxygenated blood as you're doing CPR going through the circulation.
Yeah, I think our pre-morbid disease in our medical patients, especially with ARDS or severe respiratory failure, definitely helps me understand why they may not benefit as much from ECPR.
Yeah, yep.
I've also read that maybe cardiac patients with anatomic abnormalities, traditional CPR may not be as helpful for them.
Helpful, yeah, that is true, yes.
Okay, so now say you're in the ICU and you're deciding if a patient is likely to benefit from ECPR in the case of a cardiac arrest. What are the key features that you consider?
I think most important is their underlying disease process. What are the comorbidities that this patient already have? And what really is the reason for their cardiac arrest? So as I said, let us take many of our intubated sick patients. A big cohort of them are hem-onc patients. And all of us who are in the ICU have that experience. You get a hem-onc patient who is either status post bone marrow transplant or is febrile neutropenic and who comes into your ICU, and then they have either septic shock or ARDS, and then they arrest. And we know septic shock by itself has, compared to ARDS, has worse outcomes. And then you add ECPR to that, then it is even more. Similarly, ARDS in a hem-onc patient, if they arrest, then you are really in trouble because they should have other comorbidities. So these are probably patients who are not very good ECPR candidates. But let us say you have an asthmatic that comes to your ICU, you're going through the pathway of asthma management, and you say, you know what, I have to intubate this patient. The last thing you want to do is intubate an asthmatic patient. So at that time, probably it's a good idea to think that, okay, during the process of intubation, what if this patient arrests? Should I be cannulating? Of course you should be cannulating. And so preparing ahead, letting your surgeons know, having your ECMO pump at the bedside and say, I'm going to intubate this patient, and if they do arrest, I'm going to cannulate them. Those are probably good patients. And the other example, as I mentioned below, is you're in the ER or you are in the ICU and you think this patient has a foreign body that they've aspirated. You recognize that either by their clinical, this one, and we had that case. I don't know if you remember, Zach, but I think those are patients that I would certainly think about saying that I'm going to do. And even let us say you have a otherwise healthy septic shock patient that you are preparing for cannulation and the patient arrests, then of course you're going to say, I'm going to go ahead and cannulate the patient because I'm ready to cannulate, knowing that maybe you are going to have some morbidity. But I think that's a good idea. Yeah.
It seems like the learning point would be if you have a patient with single organ failure who has an immediate decompensation due to reversible cause, that might be the best patient.
The best patient, correct. Yeah.
So stepping back, how do you think about ECPR candidate versus regular ECMO candidate for a patient that's already admitted to the ICU?
Again, let's go back to the hem-onc patient that we were talking about. So you have a kid who is having some underlying pneumonia from their cancer, and now they are in toxic ventilator settings. Should you be thinking about cannulating them for VV ECMO if they have ARDS? I think so. And our own center experience and one of our fellows, Colin, who did the multi-center study, we found that they actually have pretty good survival. A decade ago, Gao et al. Actually did a survey and looked at the ELSO registry before 2010 what their survival was, and we saw later in the registry what their survival was, and we saw there was an improvement in survival. And our own center experience, and now this multi-center study that is soon going to be published, we know that offering VV ECMO may be a good idea to these patients, and you can bridge them through their illness and get them back to where they can go back to their cancer treatment and eventual recovery. And we see actually a few of these patients come back to our ECMO reunion, and it is definitely a great one for us, for sure. But if that patient arrests in your ICU, would you be thinking about ECPR? Probably not.
Yeah. So the learning point may be your patients who are accruing multi-organ failure, maybe you can offer them ECMO, but ECPR might not be in their best interest.
Might not be the best interest, correct. Yes.
Okay, that's helpful.
Yeah.
And everything's a case-by-case basis. Especially
Case
depending what you
basis.
have.
Yeah, and also remember, these are all multidisciplinary patients with multiple specialties involved. And so it always has to be a team decision. And that's what we do, as you know, Zach. We do that in our PICU. We have oncology, we have surgery, we have cardiology in some cases, and we make a multidisciplinary decision to say, are they candidates or not? Yeah.
Your understanding of literature and understanding of what's practiced nationally, do you think there's currently a role for ECPR for an out-of-hospital cardiac arrest?
Not in pediatrics. I think that's a very slippery slope that you'll be going through. I think there is a big momentum in adults, and that's because many times it's VFib cardiac arrest that they are in, and there is so much momentum. In fact, the first randomized study came out of Minnesota. There is another one from Prague. So there are multiple adult studies, but in pediatrics, I think it is very challenging as to what the reason for out-of-hospital arrest is, who is doing the CPR, how long is the transport, and is your ER really equipped to do ECPR? So there are multiple players. But having said that, let us say it is your congenital heart disease patient with a well-known lesion, well-known problem, who parents have been educated to do CPR. They have an arrest and then they are brought into the hospital. Sure, you want to consider them, but I think that is a very small population in pediatrics.
Okay. Maybe the learning points are because of the higher rates of respiratory arrests and the technical issues that go with cannulating a baby in an emergent situation, maybe they're not as likely to improve with ECPR. But the caveat could be if you have that patient who has a known congenital cardiac abnormality and the linkage of support could be intact enough that perhaps that child could be
Perhaps,
offered
yeah.
ECPR.
Yes.
So maybe we'll reset and come back to more nuts and bolts practical mindset, how you are at the bedside. So say you're working a shift in the PICU, a patient that you've already identified, they're going to be high risk of arrest, and you also identified them as being an ECPR candidate. At what point after the cardiac arrest during the resuscitation would you typically activate the ECPR team? Should you call them immediately or maybe after the first dose of epi? How do you do that?
Yeah, I think every hospital should have a protocol. I think that's always helpful. And then first and foremost, I want to tell for the listeners out there that if you are a new program, I would say shy away from doing ECPR, because ECPR is for a well-established program that has all the nuts and bolts, as you said, have it all ironed out. So usually we say the first dose of epinephrine. Usually the team leader is very good about asking the question, but otherwise you have to remember in your own head, when I'm giving the first dose of epinephrine, is this patient a ECPR candidate? If the answer is yes, then you start activating the team. Every hospital has its own policies and procedures, how they do it. In our institution, we have a blast page that goes off to the surgical team, the OR team, the anesthesia team, the ECMO specialist, and in the PICU, typically the ECMO attendings. You have to make that decision very fast because you can always call it off if you have a ROSC. But every minute you delay, you're delaying their ability to establish flows.
Right. And I know one of the first conversations that happens when the surgeon comes to the bedside between them and the ICU attending is, what size cannulas do you want and where do you want me to place them? How do you think about choosing a location for cannulation for ECPR?
So in the cardiac ICU, it's, I think, pretty straightforward. If there is an open sternum, then they always go for central cannulation because that's the easiest. But if it's a closed sternum, it's depending on the underlying lesion, what the reason, and the surgeon and the OR availability, they go between peripheral and central cannulation. In the PICU, your choices are typically only peripheral cannulation, but do you choose the neck versus the groin? And I think really it bogs down to the size of your patient, the comfort of your surgical team, that you make those decisions. We say anybody over 30 kilos can technically be cannulated in the groin. But again, as I said, it depends upon the comfort of your surgical team and this one. The advantage of doing groin cannulation as you're doing ECPR is the CPR can be uninterrupted. And the groin cannulation, you can potentially have two surgeons working, one on the vein axis and one on the arterial axis, which makes the cannulation faster. And that is what they do in adult ECPR. As soon as the patient comes, it's typically done many times in the ER. They have two surgical teams, one cannulating the artery and one cannulating the... It really bogs down to the size of your patient, how much flow, what size cannula you can get in so that you can establish the necessary flows and your comfort of your surgical team.
Sure. So maybe a take-home point would be if the child's over 30 kilos, you'd like to preferentially go for the groin access, especially because the risk of stroke is going to be so much higher in those older children. So say your patient has an arrest, you activate the ECPR response, and you're working on getting access, getting cannulation. How long should it take for an ECPR to be deployed and put the patient on the pump? And at what point is too long and maybe this is futile?
You always hear of cases, they'll say, oh, they went on for 75 minutes, they went on for 90 minutes, and the patient survived. But I think there are now at least a few studies that have shown the longer the duration, the worse are their outcomes. So people typically say 30 to 45 minutes is the need to establish flows. But again, can then be one patient who you are now at the 47th minute, you are very comfortable with the quality of your CPR, you are following gases, you are looking at their pupillary response. Though in hypercarbic arrest, you don't want to hang your hat too much on your pupillary response. You're comfortable with that. Would you be going on to cannulate? Probably yes. But typically we say 30 to 45 minutes is a good ballpark to have to get on the pump.
Sure. And it's so difficult to do it any quicker than that, it seems.
Yes. Yeah. In adults, they've been able to do.
Yeah, for sure.
Yes, for sure. Yes.
So as we move towards the end of our conversation, does anything else come to mind that maybe I forgot to ask you that you'd like to share with our listeners?
I think the key points, as I said to the listeners out there, is that one, remember that it requires a huge amount of resources. It is a high stress situation requiring multiple teams to coordinate. And so you need to be an experienced program to do it. Then second important thing is identify your candidates early so that you're well prepared and you're not struggling in the last minute, because that is certainly something. And then the other important topic that we haven't touched on, and that is something that AHA stresses and institutions have to follow, is post-arrest care. How do you do it when they go on ECMO? And that is certainly something that you have to think about. And it again bogs down to your candidate, the cannulation, how effective is your CPR, and what are the strategic things that you can do post-arrest to manage these patients. And then lastly, important to follow and learn from your own experience. And nothing is more valuable than that, because you learn from your own experience. And say, if you are really interested in ECMO and you are the ECMO medical director or you are on the ECMO team in your hospital, track your own progress and say, where are my opportunities to improve? What could have been done better? And that's always the key to make ourselves better in whatever we do. And also, if you don't know the answer, reach out. ECMO is a very close-knit community. There are enough resources. There are enough experienced people. Talk to them. And that's how I learned ECMO, talking to people and making phone calls at all times of the day and night.
Well, thanks so much. This has been a great conversation. Definitely not the easiest topic, because so much that we discussed today is so dependent on your local institution.
Exactly. Yeah, for sure.
Last question for you. Any recommendations for our listeners could go to learn more about ECPR or ECMO in general?
ELSO has published a lot of guidelines, and if you're a neonatal pediatric person or an adult person, there are guidelines which kind of help you to understand various topics. And it is a fund of knowledge that has been put together by experts, reviewed by experts, and only then published. And then second, if you want more knowledge and more this one, certainly a red book is another good resource to go and read some chapters on physiology and other this one. And then lastly, of course, following some of the publications that come along and learn from those. So there are plenty of resources, and always I encourage people to attend ELSO meetings where there is a lot happening. And I know there are lots of meetings for fellows to go to, so to pick and choose may be difficult. But if this is an area that interests you and you want to develop some expertise and learn further, then that is certainly an opportunity to get some experience, network with people, and learn more. And that's how I have grown in my career, for sure.
Great. Yeah. Well, this is a great way to end our episode. Again, I wanted to thank you so much. I think this was a really helpful discussion and definitely something I wish that I had access to a year ago.
Yeah. Thank you, Zach, for doing this. This was fun, and I hope the listeners enjoy it as well. Thank you.
They will. Thank you. And thank you for listening to this episode of PedsCrit. Please remember that all content during this episode is intended for informational and educational purposes only. It should not be used as replacement for medical advice. The views expressed during this episode by hosts and our guests are their own and do not reflect the official position of their institutions. If you have any comments, suggestions, or feedback, you can email us at pedscritpodcast@gmail.com or find us on Twitter @CritPeds and @PedsCrit on Instagram for real-time show updates. If you enjoyed the show, please subscribe, rate, and review in your favorite podcasting application and share with your colleagues. Also, if you'd like to support the making of the podcast, please see the description for Venmo information and how to become a Patreon. Any donation will be appreciated. Thank you again for listening, and goodbye.